And thank you very much for joining. Fantastic to be able to introduce Cyril or Sitambisu Makulu. I hope I didn't do too bad a job of that as a presenter this evening. Cyril and I have actually known each other for many years. Cyril actually qualified as a registered nurse about 25 years ago in haematology and got his haematology nursing diploma from the Thames Valley University in London in the UK. Probably around not long after that we met in the haematology department here at the hospital where I'm still working. He's moved on, but I'm still here. He got his diploma in critical care of the ill cancer patient, also from Thames Valley, but in association with the Royal Marsden School of Nursing. And he's also completed oncology patient navigator training, looking at fundamentals of that in Washington, DC. He's worked for National Health Service Trust in the UK at the Hammersmith, the Royal Marsden and King's College Hospital here. He's also worked as a haemophilia nurse coordinator, which I didn't know about, for the KZN province in South Africa. He's worked as an oncology nurse navigator for Netcare in Durban and Johannesburg, and he's currently a unit manager for the oncology ward at Wits Donald Gordon Medical Centre in Johannesburg. And he's also currently the co-chair for the Blood SA Haematology Nurses Working Party. So it's a real privilege for us to hear from him this evening, talking about invasive fungal infections in our transplant patients. He also very proudly was part of the JC accreditation effort for Wits Donald Gordon Medical Centre in 2025, which is a really incredible achievement. Welcome, Cyril.
Thank you very much. I'll start by apologizing for a glitch. Yes, and thank you, Michelle, for such a wonderful introduction. I am Mr. Cyril Mtimkul from Wits Donald Gordon, and today we are going to talk about invasive fungal infections for post-HSCT patients. But before we go any further, this classroom is actually brought to you by Blood SA in collaboration with eBMT. Few notes, like housekeeping notes. The recordings, all sessions are recorded and can be found at the moment on our website, but in the future, hopefully soon, we will. Nicole will correct me if I'm wrong. They will be found on our YouTube very soon.
Yes.
You are more than welcome to add any questions or comments to the chat box during the meeting or this class, and we will respond to them at the end of the presentation. I know there were questions about CDP points. Until it is approved by South African Nursing Council, then maybe we can go back and fetch those CDP points for everybody. But please attend this meeting for at least 45 minutes. We do have a WhatsApp group, and of course, everyone is in that group. I'm sure you all know that, but the feedback is also important. So yeah, let me jump into it as well. Now I've lost a bit of time. So we're talking about invasive fungal infection post hematopoietic stem cell transplant. I like this quote actually, which I find in a South African medical journal. We know that the growing need for hematopoietic stem cell transplant is reflected in the increasing number of transplants performed globally each year. But its success depends on optimal outcomes of various stages of the procedure. First of all, there has to be a patient. We have to have a cell, or we have to find a donor, or even from the patient itself. But then there are challenges here in our country, in South Africa, which include high cost, limited infrastructure, and lack of appropriately trained staff, as well as limitations in securing suitable hematopoietic stem cell donors. Again, in South Africa, invasive fungal infections are a significant complication of stem cell transplant recipients, with an overall incidence of approximately 4%. And the most common pathogens identified in South Africa in clinical settings, they include Aspergillus and Candida species. So we know that as much as we know that hematopoietic stem cell transplant is life-saving, but then the profound immunosuppression also causes an increased risk of infection for our patients. And one of them is fungal infections, which is a major cause for morbidity and mortality. So early diagnosis still remains a challenge. So this I got it from a slide from the EBMT meeting. I think this one is the Portugal 2018. And Lydia said infectious complications are a universal problem. And we know that hematological malignancies as well, they also cause an impairment to the immune system where again, hematopoietic stem cell transplant also directly affect the immune system for our patients. So she went on to say, because of prolonged neutropenia and other problems, um, patients are susceptible to opportunistic infections. And obviously, if diagnosis is delayed, it would increase mortality. It's a very good read, and one can find it on the EPMT website. Very, very good read. So epidemiology, we know that types of transplants that we do is autologous HSCT, which actually those patients are at a lower risk of infection, especially fungal infection. Whereas the other group of allogenic HSCT patients, they are at higher risk, and the incidence is between 5 to 15%. Why? Because of prolonged neutropenia, graft versus host disease, immunosuppressive therapies that we use for them, and broad spectrum antibiotics use, and again, CMV reactivation. The common or most common pathogens are Aspergillus fumigatus, Candida albicans, and Mucorales. And many, many more. There's quite a different names of these fungal infections. So let's look at the Aspergillus. Um, there is Aspergillus fumigatus, like I just said, it is the most frequent species causing invasive fungal infection. And other species that are often detected are Aspergillus niger, Aspergillus terreus, and Aspergillus flavus. Aspergillus infection commonly presents as invasive pulmonary aspergillosis. I think that's what we see most often. The allogenic HSC patients, there's 3 periods of increased risk for them. That is with invasive aspergillosis and other most disease will occur. First is during neutropenia following the conditioning regimen. Second phase is during acute GVHD. And the third phase is during chronic GVHD. I'm sure everyone who has actually looked after these patients, they would know that our patients will have neutropenia phase a few days after infusion of cells. And then they would develop acute GVHD between day 5 up to 30. And then the chronic phase will happen later, probably around plus 100 days going forward. So the risk is higher during GVHD than during neutropenia due to the use of chronic immunosuppressive therapy. And then the other species is Candida. Candidiasis is a common, often severe fungal infection in post-hematopoietic stem cell transplant patients, frequently caused by Candida albicans. Candida species are the second most common cause of invasive fungal infection. So the highest risk occur during the neutropenic phase, that is early post-transplant, and when taking immunosuppressants for graft versus host disease. And again, other risks include oral colonization, damage to the gastrointestinal mucosa and the presence of central venous catheters. I'm sure we've probably seen that our patients would end up with oral thrush and all because of worn out mucosa, oral mucosa, then they end up picking up fungal infection. Then there is another one, mucormycosis. It is a rare one, but a life-threatening and angio-invasive fungal infection. And it is the major cause of morbidity and high mortality, often around 60 to 90% in patients post hematopoietic stem cell transplant, particularly in allogenic recipients. It is also characterized by rapid progression, often causing tissue necrosis and requiring early aggressive intervention. Mucormycosis often presents as a late event after hematopoietic stem cell transplant with a median time of 135 to 125 days post HSCT. Pulmonary involvement is the most common for for this group of disease, often presenting as pneumonia that does not resolve with standard antibiotics. Um, the diagnosis is often challenging as blood and sputum cultures often yield negative results. So it's always difficult to quickly find out what's going on with this type of invasive fungal infection. So other types, we all have heard about PCP and Cryptococcus. Some patients, they present with um, Cryptococcus meningitis. We've seen that. And I've never heard of endemic fungi, but it's out there as well. And then let's look at the diagnosis. As nurses, we have to understand the patient's journey and the stages of their transplant and what could go wrong at each stage. And then, therefore, high clinical suspicion is important. Obviously, most of the time we rely on blood cultures. I always say, as hematology nurses, we talk blood, nothing else. Again, the use of CT scans. If for instance, for Aspergillus, CT scan will show like a hollow-like structures in the lungs if it's present there, and then fungal biomarkers like galactomannan and beta-D-glucan. BDG is found in several organisms, including Candida species and PCP, and molds such as Aspergillus species and Fusarium species. The galactomannan is another fungal cell wall biomarker, or biomarker rather, produced by several fungi, including Aspergillus, Penicillium, and Histoplasma species. And then the use of Fungitel, and it's common, especially where I work. We quickly run into doing a Fungitel if patient has got a prolonged pyrexial phase and it's not actually responding. So then we would do Fungitel, and it's one of the reliable tests as well. And then you would do a histopathology, which is a tissue biopsy, which is again a gold standard test, especially in invasive aspergillosis, pneumocystis, and endemic fungal infection. So I did say that there are other types as well. We do cryptococcal antigen test if patient is presenting with suspicious symptoms that are suspicious of meningitis. And Aspergillus polymerase chain reaction. So PCR actually now is commonly used, and there's quite a variety of that. I only just mentioned those that you can see, the Aspergillus polymerase chain, Candida PCR, Aspergillus PCR plus a galactomannan, and they seem to be working very, very well as well. So it's exciting to see that some people are working overtime to try and find the better ways of managing invasive fungal infections for our patients. So looking at the management, this is medical management for these patients. Early recognition is really important so that we can start a treatment as early as possible. And this will obviously improve the patient's outcomes. So effective management strategies include prophylaxis, that is primary and secondary. Primary, those patients would be started during at the start of the conditioning treatment prior to infusion of cells. And the common drugs that they use for that normally is fluconazole, which can be up to 400 milligrams a day, to prevent things like candida and yes, and then you have posaconazole, which again now is used widely, and that's what we use at our hospital. Posaconazole, especially for allogeneic stem cell transplant. The fluconazole would be for maybe those patients like myeloma patients or autograft patients, and let me put it that way. And antifungal prophylaxis is tailored to risk as well. And then there is secondary part of prophylaxis, which aims to prevent relapse of a prior infection during subsequent immunosuppression. Remember, a patient could have had uh, fungal infection even prior to coming for stem cell transplant. And so we would obviously give them some more antifungals so that they do not relapse and or find ourselves fighting the fungal infection that could have been prevented. Mostly, there's a use of posaconazole, like I said, and it comes in a suspension form. The voriconazole, it is also widely used, but sometimes because of its toxicity, and it tends to sit back and use posaconazole instead. I remember back in the day, when I started, I used to look at this capsule. I'm talking now about empiric, the itraconazole. And it was beautiful. I would look at that capsule each time I open the medication for patients. Beautiful, beautiful. But it has problems, especially the toxicity, kidneys, and problem and all that. So this empiric part of treatment and all prophylaxis is considered after 3 to 5 days of broad spectrum antibiotics and persistent or recurrent fevers. I just mentioned the drugs of choice for that category, like itraconazole. We don't actually use it here at my hospital. I'm not sure about around the country. Remember that the infection varies around the world, and so sometimes they would look at which more is sensitive in the area. Caspofungin, it's been years since I used it, but it's out there as well. And then the liposomal amphotericin B, I'm sure it's very expensive here in South Africa, but it's part of the treatment as well. And again, voriconazole is there. And they are just quite good drugs, but let's look at the nursing management. Um, which is because nurses are there 24 hours. So this is the most crucial part of detecting and assisting the patient from falling apart because of invasive fungal infection. So as nurses, obviously, we have to assess and detect signs of infections as early as possible by monitoring patients for signs of infection, that is persistent fever, and if they are not responsive to antibiotics. Patient may have an irritating and a persistent cough, dyspnea, pleuritic chest pain, and sinus pain, nasal congestion, sometimes skin lesions, and necrotic or nodular stuff, and altered mental state. I did not put any pictures because I thought my slides were too busy with information, but it would be nice to see that skin lesion, and which I decided not to put on here. And so these are the things that we should worry about if they are happening to our patient, especially that persistent cough, and then all of a sudden they are dyspneic and with chest pain. Those should be reported immediately. Um, but then again, it's important to inform the patient to notify us as nurses if, for instance, they're feeling that pleuritic chest pain, and they see some lesions that are not familiar with. It's important that they report that as soon as possible. But then us as nurses, we should be doing our own physical exam, especially to these patients. There is always a chance to do that. And then vital signs and monitoring. So obviously we have to monitor temperature at least every 4 hours and escalate if things change. And continuous oxygen saturation if pulmonary involvement, and monitor hemodynamic stability for the patients. Um, and then obviously there will be some diagnosis that will be carried out or be requested by the doctors. So as nurses, we have to be supportive of this and make sure that they are happening as quickly as possible, like blood cultures. And obviously they will run the serum galactomannan testing. Bronchoscopy, it's used quite a lot now. I'm sure we do quite a lot of them at Western Gordon. And obviously the CT scan, especially to the chest, like I said earlier on, it would show some changes in the patient's lungs, like some hollow, like or patches in the lungs. And then our biggest role is infection prevention and isolation. So we need to put this patient in a protective isolation that is, if we like to call it, negative pressure room. Oh, positive pressure room. And then there is should be in a HEPA filtered rooms if available. So that's another challenge in our country. But except where I am, the last 4-bedded unit has got is actually HEPA filtered. And then a strict hand hygiene to everyone, including visitors, the other hospital staff that are coming to take a patient, or sometimes the phlebotomists, because we use quite a lot of phlebotomists from the labs. So they should be observed and or are advised to observe their hand hygiene. And obviously limit visitors. So this again is important. I always say during the at the meeting prior to transplant, because sometimes some of the families are there. These things should be mentioned to them, that there will be a chance that we would limit visitors, especially our patients is neutropenic, and all the family, if ever anyone has got any cough or anything, probably might not be allowed to come in to visit the patient. Here's the argument. No fresh flowers or plants. I still maintain that, and I'm still putting my foot down for anyone, visitors or anyone to bring fresh flowers in my unit. Although the debate is about they are breathing the same air we breathe, and they go to same shops that we go to. So they are exposed as much as we are as well. And what's the difference? Because there's not a proven research on fresh flowers and causing infections to patients. But like I said, I just want to see it in black and white, and then maybe I will change my mind about allowing flowers into my unit. The neutropenic precautions as well. important, like neutropenic diet. Thing about green salad as well, fresh salads, what they may cause the yogurts and all those things. So there's a chance of that you will never know whether it's grown as something. So it's important that patients are advised against that. And then environmental precautions. Patients, especially in the early days of transplant, they are excited, they are out there, they want to see the world again after isolation for such a long time, 3 to 4 weeks, sometimes longer if they've got prolonged infections and what. So we should avoid them to, I mean, should advise them to avoid construction areas, and because there's a risk of aspergillus spores. I remember when I started as a hematology nurse, they were not even allowed to spend time and interact with their pets at home. I'm not sure if things keep changing now, but I still maintain and advise them that yeah, it's always nice to see your dog around, but it's painful for them when seeing you avoiding them and or not giving them time, but they also could cause a risk of infections. We advise them to use mask when they are outside, going to the malls. It's important. And whenever they've got visitors at home, because some people they've missed them for so long, and they would want to visit. As much as we try to minimize that, but some people will still come to visit them at home. So the use of mask around those, because sometimes people don't understand if you say they should not come in because they're sniffly and all that. The excitement of Cyril is back home, let's go and see him, and yet they could cause a threat to him as well. So obviously these patients are put on treatment, the antifungal therapy management. So as nurses, we have to ensure that we administer them correctly, a correct dose, and infused in a correct rate, especially drugs like voriconazole. You have to have a lot of knowledge as in terms of how much you mix it with in terms of the fluids, and obviously the rate that you should run. It can only be given through an infusion pump, so just to make sure that it's running in a correct rate. And obviously for other drugs, you may have to pre-medicate patient, like for instance, amphotericin B. A few years ago, I had a patient that reacted badly to amphotericin B. And there's two types actually of the amphotericin. There's liposomal and I can't remember the other one. But patients tend to react badly to one of them. Again, while you're doing that and giving medication to these patients, you have to monitor for side effects. And that's another thing that sometimes people ignore, to tell the patient that you're starting them on amphotericin B, for instance, and here are the side effects that it may cause. So it's important they are told that, because like amphotericin B may cause nephrotoxicity, hypokalemia, that's for us as nurses to check on UNEs for the patient, and sometimes infusion reactions. The or voriconazole may cause visual disturbances and hepatotoxicity. So it's important that we communicate with our patients. Posaconazole may cause gastrointestinal upset and or liver function. Caspofungin, it's been years since I use it, but again, may affect the liver enzymes and again may cause a reaction, infusion reactions. So it's important that patients are well informed about these. Um, and the take home points. I think I missed a slide. Did I not? Because they should be. Oh, okay. I just wanted to add something on patients' education. Psychosocial support. It is very, very important. Because patients, when they see all these things, unresolved neutropenia, temperatures, and other things that are happening, which they're not familiar with. They then fear of relapse. They're thinking, oh, as the transplant failed, and then isolation distress. It's so important for us to offer them emotional support, not just the patient alone, the relatives as well, because they are stressed about what they are seeing, because we are still labeling whatever kind of cancer as for them, they think it's just a death sentence. And then patient and family education. I've mentioned quite a few when I was talking. Um, Advise patients to report fever immediately. We all know how important that is for our patients. If it's early detected, the chances of patients recovering quickly and not actually ending up having severe infections and may again lead to mortality. It's important that we catch these things early. And like I said earlier on as well, the early days of transplant, when they got out of the hospital, they have to avoid gardening and soil and things like that. And again, the oral hygiene is so important. Always important. Patient has to um, um, did that as like religiously. They have to do that religiously, and they must adhere strictly to antifungal treatment if it's given, because sometimes they can take these drugs up to 6 months or even more if the fungal infection is stubborn. And Recognize medication side effects. I did mention that earlier, but they would only know about that if you were clear, you gave them clear information about the side effects that they may actually experience. I thought I would add that as well. So here are the points to take home. Um, Early detection of infection plays a big role. And so us as nurses, we have to be clear. Like I said earlier on when I opened the conversation, that as nurses, we have to understand the patient's journey throughout the process of transplant. And health education, otherwise we would miss anything if a patient doesn't know that they have to report any unfamiliar things that they see, especially with some rashes, that pleuritic pain in the chest, um, and obviously safe antifungal administration. It's important as well. Like I said, the faster you give some of these drugs, they may cause problems. And again, know the drug interaction. It's important as well. So I've spoken just recently about infection prevention for both or everyone, patients, hospital staff, and the relatives. And again, then respiratory monitoring. Just mentioned about that pleuritic pain, dyspnea, and all that, and all the fluctuating oxygen saturations. We should worry about that, especially if they are occurring frequently. All of a sudden, everything is been well, but now there's a point where they keep dipping below the normal range. Social support, I could never emphasize it more enough. It's important as well. And patient and family education. So we have a big role to play as nurses when we are working with our hematology patients, especially those who are post-transplant. Um, Another thing that people should be aware of, I did say that as much as it's a autograft patient or autologous stem cell transplant, the risk is lower, but we cannot just sit back and relax. In a country like South Africa and or around Africa, but I'm going to talk about my country because I've never been in any other country in Africa. One of the problems is HIV. And because those patients are immunosuppressed, so you can just imagine what could happen. They stand a chance of catching fungal infections as well. Sometimes there is drug interaction with some of the drugs or antifungals that we use, so it could cause a lot of problems. Um, with the allogenic stem cell transplant, like I said again earlier, that the risk is higher. Um, why? Because of the myeloablative drugs that we use as preconditioning. Um, let me talk more about that as well. The risk is higher if patients are using, which is really used now, the intensive myeloablative conditioning, because it causes a prolonged neutropenia for these patients. So they are at risk of developing invasive fungal infection, and may cause, then become susceptible to all these opportunistic infections. Um, Whereas there are other group of patients, sometimes they get the radiate TBI only. Um, it is better than anything because it doesn't affect the neutrophil count a lot, and the recovery of the neutropenic phase for those patients is quicker compared to other groups. But now we are using the not so much of intensive conditioning, and patients neutropenic phase recovery is quicker, and obviously the risk is then not so bad. Patients they recover quickly, but then again, like I just mentioned, HIV as well. So you can just imagine someone who's already immunosuppressed and going through the such conditioning treatments, then those people sometimes it tends to take longer for them to recover from especially neutropenic phase. Um, so those are the things, are key points that again I think we should be aware of, how preconditioning affects and or will lead us to what problems for that patient. So it's important that we know um, that if a patient is having a fever more than 5 days and is persistent, then we should start worrying about what's going on here and start doing tests and physical examination and all that, because that could indicate that the patient has caught a mold of some sort, could be a candida or aspergillosis as well. So I love hematology, and when you see all these things happening and how we jump to try and make sure that it doesn't go any further, I get excited. Yes, I feel sorry for the patient, but for me, I feel like I know what I'm doing here, and I could actually help here, especially with the diagnosis part. It's very important. That is why I think we are having these trainings so that everyone should be comfortable to, if they need to deal with such situations and move quicker. And obviously, patient support is important. Um, I think I've done my part of talking, and now I would leave it on the floor if there are any questions or comments or contributions, and I would really appreciate that. I'm going to stop sharing now, and thanks again for being here and listening to my talk. I hope it made a difference.
Wow. Well, thank you so much, Cyril. That really was an excellent presentation, and I certainly learned some things that I didn't already know about fungal infections in our patients. I just wondered if anybody does have any questions. If not, I do have a couple of questions. Um, so I might start unless anybody raises their hand or speaks up or puts something in the chat. Okay, so Natasha has asked a question. So Natasha has said that damage to the GI tract and the mouth from chemotherapy allows the candida to enter the bloodstream. Absolutely correct. Have you seen a correlation of increased fungal infections with patients having persistent mucositis or prolonged gastrointestinal tract adverse effects? Sorry, you're muted. Sorry.
My quick answer, Natasha, no, I haven't. But then again, we've had patients that have been struggling with candida after a transplant. Um, I think, telling a lie, I think when I started at vets, there was this young guy who had actually had a bad GIT, and he struggled. And unfortunately, we lost him, but not because of just fungal infection. There are so many things that were going on. Like I just said again, that in South Africa, sometimes our patients and our community, they struggle, they have underlying disease apart from hematologically. But yeah, I think only one guy back in 2023.
Thanks, Cyril. Do we have any other questions or anybody want to type anything in the chat? Okay, I have a question. And I think that this question is probably not just relevant for the South Africa context, but also other countries where reimbursement can be a bit of a problem, because many of certainly the more modern antifungal treatments are very expensive, particularly for prolonged treatments. And if you kind of consider that a treatment package could include kind of 6 to 12 weeks of therapy, including reassessment scanning during that period of time. How's that managed generally in South Africa?
Um, I work in the private sector, and patients have got medical insurance and
Yeah,
or medical aid. So I think for such patients, private patients, some of the things are accessible depending on your insurance. But the medical aid will cover everything. I can't remember now on top of my head up to how many days post-transplant that you'll have access to this treatment. But it's a long journey, so they are covered. The struggle is at the our government hospitals
yeah,
because those people don't have money. And then you can imagine if you have a population of maybe even roughly 100 patients that require HSCT. So how much that hospital or the government is going to spend on those patients if the complications are too much. So it's still a struggle with our government hospital, but they are trying.
okay.
Yeah.
Okay, that's great. Thank you very much. Does anybody else have any experience? So, in government, mostly fluconazole, ampho, hopefully the liposomal maybe, and vori. Yeah, so things like caspofungin, you don't
Mm.
have access to necessarily. And of course, with the other agents there, I mean, not necessarily fluconazole, but ampho and vori, the side effect profiles are quite considerable, and it's kind of, you know, uh, balancing that, isn't it, between the treatment.
Mm.
And I guess that moves me on to just another question about side effects, and if you had any other tips, or anybody on the seminar this evening had any tips about managing side effects of antifungal therapy, because again, it's a considerable commitment for many of these patients. You're talking about 12 weeks, sometimes longer of treatment, which can be difficult to manage, especially if we're using intravenous preparations.
I think anyone can answer that question.
Yeah,
I'm an office person now, not clinically involved that much with with patients. Um, but obviously, sometimes these patients will be we've seen in outpatients, and if they have to continue with IVs outside the hospital, they would have that done in
yeah,
outpatients. And sometimes, if the medical aid is able to support, and then we can send a nurse, not from the hospital or community nurse, to assist a patient at home in their beds, other
yeah.
than traveling back and forth almost 5 days a week to outpatients. So that's another option that can be offered to them.
Great. And
And
can I just, sorry, go on.
Oh, I was just going to say, in my talk, I did say that health education and recognition of side effects is important.
Yeah,
Yeah, so that alone again is they have to have that knowledge, and they should have access to calling us and telling us, oh, I'm experiencing this and that. Um,
yeah,
some we know that sometimes they struggle with nausea and vomiting and all that, especially if they have to take oral medications. And how do we advise patients to deal with that? Again, that is important. Sometimes we would advise them with home remedies, things like I found at some point that lemon and ginger tea was actually good when patient were taking that. So it's important for us as nurses, especially in this specialty, that we always have an answer and an option for a patient to try.
okay. Okay, great. Yeah, and of course, there's all the electrolyte imbalance with some of the
Yes.
preparations as well that can be
Mm,
difficult to manage. So patients require additional treatments, oral or intravenous.
mm,
Um, yeah, yeah.
mm.
Do you, for the hypokalemia that you have, Dashandri, do you also use amiloride as a potassium sparing diuretic at relatively low doses? 'Cause that can be quite useful in terms of enabling potassium retention during prolonged treatments with amphotericin. Okay, so it's a potassium sparing diuretic that you can use at low doses, and it helps it prevents the kidneys from leaching out so much potassium
Mm,
during the
mm,
amphotericin treatment period,
mm,
and can
mm,
be really helpful in minimizing some of the potassium replacement and then subsequent magnesium replacement that's required for some of the patients. Um, so that might be worth thinking about in your practice, having a chat with your medical team.
mm.
Um, any other questions at all? I'm conscious that we're almost at time. Uh, so we have another session planned for next month. Cyril, that's right, isn't it?
Yes, a month today. It will be a 26th again. Next month, March. Yeah, same
That's right.
time. Yes.
Great. So, well, thank you very much, everybody, for joining. Do share the information about this session with your colleagues so that they can sign up and access the sessions through the BMT Classroom, as Cyril mentioned right at the beginning of the session. And we hope to see you all and some of your colleagues at the next webinar. Thank you very much.
Thank you, Michelle. Actually, I didn't check how many people attended today, but it was quite a big turn up during the week, people who wanted to attend this class. So I'm excited.
Yeah.
And obviously, we are making a difference, and I'll be even more happier if we see many, many more. Thank you so much, everyone, for your time. Have a great evening.
Thank you very much. Bye now.
Bye bye.